Good afternoon. You are here at the NCRC panel, Sick to Debt, and we have a great panel for you today to look at medical debt, the issue of medical debt, and what's happening at the federal level, as well as do a deep dive on one state-based advocacy campaign that addressed medical debt issues. My name is Marceline White. I'm the Executive Director of the Maryland Consumer Rights Coalition, MCRC, and I'm also on the board of the National Community Reinvestment Coalition. So I'm thrilled to be here today. With us, we have Jennifer Bosco from the National Consumer Law Center, who's a national expert on medical debt issues. And what we're going to be doing as a format is Jennifer's going to be talking about these issues at the federal level and give you an overview of medical debt issues. I will then talk a little bit about our campaign in Maryland and what we did and what the bill does. And we will be able to answer questions at the end. If you want to put questions into the chat, we can also answer some questions throughout the presentation in the chat, and then we'll have about 15 minutes at the end to answer additional questions. We are both going to show a slideshow, so those will be available for folks after the conference sessions as well, so you can have those. So with that, I'm going to turn it over to Jennifer Bosco. We're thrilled you're here, and thank you for taking the time to provide an overview of these issues for us.
Sure, and thank you for inviting me. I'm going to go ahead and share my screen. Well, welcome, and I'm Jennifer Bosco. I'm a staff attorney at the National Consumer Law Center, where I work on medical debt issues as well as some other consumer issues. And here's what I'm going to be covering today. So I'm going to go over a little bit of background information about medical debt and the parties who are involved, the different payers who we tap for medical costs, financial assistance policies, otherwise known as charity care, and we're going to look at different areas for medical debt reform, some approaches to address medical debt before the debt's accrued, so to address the medical bills, and then after debt is accrued. Then I'll talk a little bit about NCLC's model Medical Debt Protection Act, and also touch on a few pieces of state and federal legislation that are out there right now. So just to give you a sense of the scope of the problem, medical debt is one of the most common kinds of consumer debt. And over half of the items on credit reports in this country are for medical debt. And even though we've had great advances with more people being able to have insurance under the Affordable Care Act and more comprehensive insurance benefits, this does continue to, medical debt does continue to be a problem that plagues consumers. And over half of bankruptcy filers report that medical debt was one of the causes of their bankruptcy. 1 in 5 credit reports have an entry for medical debt. 1 in 6 Americans report being contacted by a debt collector for a medical bill. And unfortunately, there is a disproportionate impact on people of color. Medical debt exacerbates the racial wealth gap. While 17% of residents living in communities of color have 1 or more medical debt in collection, it's a smaller percentage of consumers who live in white communities. The rate of people who lack health insurance is also higher among residents of communities of color. So I'm going to talk a little about parties who are involved in medical billing and medical debt collection. So when we're talking about medical debt, it's a pretty broad umbrella. I think a lot of the advocacy and a lot of the consumer rights work that we do is focused on hospitals. And of hospitals, there are kind of 2 categories to consider. There are nonprofit hospitals and for-profit hospitals. And depending on what part of the country you're in, there may be more of one type than the other. So For instance, I think in Oregon, almost all of the hospitals are nonprofit, where if you are in the Southeast, there will be a higher proportion of for-profit hospitals. They're one source of medical bills and medical debt to be aware of are emergency room bills, because emergency rooms are often, not always, but often are run by a subcontracting company. And the two most common are Envision and Team Health. So those emergency room physician services companies, they operate emergency rooms, they bill patients on their own, and they set their own prices, which may exceed what the hospital had been charging for emergency services before contracting with one of those companies. And we'll come back to it a little bit later on, but Envision and Team Health are also private equity-backed companies, and that's led to some widespread concerns about the role of private equity in healthcare. Urgent care centers can also be a source of medical debt, and freestanding surgical centers that may or may not be part of a hospital, and certainly ambulance services. Air ambulance services were in part addressed by the federal No Surprises Act to address surprise billing. So that may bring consumers some relief regarding air ambulance bills. And one source I didn't include here on this list, I realize, is nursing home debt. There are kind of particular laws that may apply to nursing home debt, but that certainly is a source of medical debt. And anecdotally, we've heard reports at NCLC that there seem to be an increasing number of debt collection lawsuits brought against the families of nursing home patients. So you may be aware of this already, but hospitals don't have a set price they necessarily will charge to every patient in the hospital for the same care. There are a number of different prices that they might charge depending on what type of insurance you have, or if you even have insurance. So hospitals all have a charge master price, which is sort of the highest possible price they would charge for a service. And due to some recent U.S. Health and Human Services regulations, charge master prices are now supposed to be made available to the public. So that's the maximum price a hospital can charge. Usually they don't charge the patient that, though, because in the second bullet, it refers to negotiated rates with insurance companies. So if an insurance company is in network for a particular, or if the hospital's in network for the insurance company, that means that the hospital and insurance company have worked out an agreement about the prices that the hospital will accept from the insurance company for that care. And those negotiated prices are going to be less than the charge master price. There are even lower prices that are paid for Medicare patients. The Medicare reimbursement rates are set by the government, and those are typically below the private insurance reimbursement rates. And reimbursement rate just means what the hospital will accept for that care. And then Medicaid tends to be even lower than that. So the only patients who really get charged the charge master rate are those who don't have insurance, or if you don't have any out-of-network benefits. So payers just refers to anyone who's being billed for the care. And for many of us, that's employer-sponsored insurance or some sort of private insurance. Within that, there are different categories. If you're a government employee, then you may have government employer insurance. There are also fully insured plans and self-funded plans. I'm going to quickly touch on the difference. It may matter when you're looking at how the authority that a state has to make rules that affect the insurance companies. So fully insured plans are traditional insurance plans where the employer will pay an amount to the insurance company, and the insurance company then bears the risk of paying out claims for the employee's health care. And employees will contribute in their paycheck usually for their plan. So those plans can be regulated by state governments. So when there's a state law that affects insurance, like a state surprise billing law that will cover fully insured plans. It cannot cover self-funded plans because those fall under a different provision of the federal ERISA law, and those are basically plans that large employers have that the employer will contract with an insurance company to handle the paperwork and the claims, but ultimately the employer is in a way the insurer because the employer is paying out those claims. So the protections for those consumers under insurance law anyway are under federal law. Medicare and Medicaid, obviously they are the public payers that many people have. And then there are products that aren't really insurance or are, in the worst case, fake insurance. So those can be short-term health plans or religious sharing ministries that don't follow the state and federal laws that apply to insurance companies and or the insurance plans. So those products are not going to be as comprehensive or be obligated to cover the same things that actual health insurance would. There are other sources of paying for healthcare bills, workers' compensation, veterans benefits. And on this list, also there's, currently CARES Act funding remains to pay for COVID-19 expenses. And so that there are federal funds that cover hospital expenses for COVID-19 and for uninsured people that cover the costs of vaccinations. And of course, then there's the patient. So when all these other sources have been exhausted, then that's when the patient gets the medical bill for the remainder. And since credit reporting is certainly an issue with medical debt, I just wanted to touch on who's involved with credit reporting. So the three big consumer credit reporting agencies or credit bureaus are Experian, Equifax, and TransUnion. Then there are the companies that are furnishers of information, such as banks and other entities that provide information to the three major credit bureaus. The users of the information, that's anyone who would pull a credit report. So if you're taking out a loan and there's a credit report generated. And there are some specialty consumer reporting agencies as well. So just to talk a little more about the credit reporting aspect of this, over half of the debt collection entries in credit reports are for medical debt. And the CFPB has done some research in the past. We're hoping there might be more in the future about the consumer impact of medical debt. Once medical debt is on a credit report, it can penalize a consumer. There's right now there's a 180-day waiting period that was part of a settlement by a number of state attorney general's offices and the three major credit reporting bureaus. So there's a settlement in place that says that the medical debt can appear in a credit report for 180 days after the date of the first bill, but that's not in federal law at this point. It's just the settlement agreement, but that is a consumer protection that's out there. Once it's on a credit report, it can lower consumers' credit score. Now I'm going to move on to financial assistance or charity care. And under the Affordable Care Act, there is a provision that says that if a hospital is a nonprofit, then it is required to provide some sort of financial assistance to needy patients. And that part of the law is actually part of the tax code. So in the IRS's regulations, there are rules about financial assistance that nonprofit hospitals have to provide. And under this, the hospitals have to create and publish a financial assistance policy. The weakness with these rules is that there's not really guidance about how much financial assistance has to be provided or who qualifies for the financial assistance. That's a lot of discretion is left up to the hospitals. So we see a lot of variation among hospitals from generous financial assistance policies to really fairly skimpy ones. So the financial assistance policy does have to be written and has to be publicized to patients. And also the policies have to follow the regulations that include some limits on debt collection actions. A number of states have financial assistance or charity care laws of their own, so that supplements the federal laws. And they vary among states. I've listed some of the states that have them here. And Marceline will talk later about the strong reforms in Maryland. So the state could apply these to both for-profit and nonprofit hospitals. And the state laws can be more generous than the federal requirement. NCLC has put out a report that reviews all the states and their state financial assistance or charity care rules, and that report is called Amounts of Prevention. It's on our website if you're interested in taking a look. So I'm going to talk a little about what can be done to help kind of work on the problem of medical billing and affordability of healthcare before the medical debt is accrued. So one of the most important things that can be done really is to make sure as many people are covered by insurance as possible, whether that's Medicaid expansion or making insurance through the healthcare marketplaces more available to consumers, and certainly the actions of the current administration to provide greater financial assistance for people who are buying insurance should really help address this problem. We'd seen rates of people having insurance improving a lot after the passage of the Affordable Care Act, but then dipped back down starting in 2017. So hopefully that trend will be reversed. Another area is to increase what's covered by insurance. So making sure that there's an adequate network of healthcare providers who are covered by the plan, and making sure that an adequate range of benefits is provided, and that a range of healthcare services are covered. A lot of plans have high cost sharing responsibilities, and that can really be a problem for consumers who, are maybe in a position where they buy a plan that has a high deductible or high amount of cost sharing because that's the most affordable plan for them, and they are not in a position to pay the premiums for a more comprehensive plan. But then if something does happen, there can be, many thousands of dollars that patients are on the hook for paying. Improving access to preventive care is hopefully a way to help ward off higher cost emergency care in the future for patients and for consumers, and covering high value care. So some states are looking at whether there should be better levels of coverage without any cost sharing for things like insulin that are absolutely necessary to the health of people who have type 1 diabetes, or there are some healthcare services that are so important that those should be covered for people who have insurance without cost sharing. So there are a number of types of reforms that states could look at. And and actually, I'm just going to move on to the next slide. For NCLC, though, we focus more on areas to look at after medical debt is accrued. So there are a number of healthcare reform organizations out there who have great proposals for the things that I just went over, but more as consumer advocates, my focus is on kind of the consumer law related pieces. So providing stronger financial assistance or charity care policies is absolutely a way to help low and moderate income patients. Eliminating charge master pricing for the uninsured. There is reporting now required of charge master prices, as I mentioned before, but requiring that uninsured patients aren't charged the charge master price, but rather are charged something that's more like the amount that a hospital would commonly accept for insurance companies, would eliminate some of the sky-high bills that we see for some patients. Surprise medical billing protections, and luckily there's the No Surprises Act that has been passed, and that's while it's not a perfect fix, that's likely to really improve the problems with surprise billing that consumers have faced. That will be taking effect, and there will be a regulatory process forthcoming. When looking at other legal protections for medical debt, other areas to look at are credit reporting and debt collection reforms. So some of those are part of the NCLC Model Medical Debt Protection Act. And this is model legislation that is available for anyone to take a look at and use the parts that you find helpful. And it is available on our website, nclc.org. And there are two main parts. The first section is about how to strengthen state financial assistance laws. So there are a number of provisions in the Model Act that would basically include the same types of protections that you would see in the Affordable Care Act, but include those in state law and add more detail about how to administer charity care and requirements about who should be covered and how much should be covered. So there are samples in that act of eligibility requirements and that sort of thing. So state laws can, they can provide, you can look at your state laws and see what kind of assistance they provide for patients and whether that is something that, could be improved in your state. One area in the Model Act that we look at is when a patient gets financial assistance, how should that be calculated? It's usually, financial assistance is usually it's structured as for very low income patients, it's free care. And for patients who are a little bit higher income, who are kind of low to moderate income, it'll be a sliding scale of assistance. So we propose in the Model Act that if you're looking at the bill and trying to decide what percentage discount you're going to give to a low income patient, that the bill should that you start your calculation with the Medicare rate, not the charge master rate, because as I talked about earlier, the Medicare rate is much lower than the charge master rate. If you're giving someone, say a 30% discount off of the charge master rate, that still might be higher than the Medicare rate. It might be higher than what some private insurance companies would have had to pay for the same care. And also in the Model Act, we include enforcement provisions and a private right of action. Private right of action refers to the ability of a patient to sue under the law to enforce their rights. And the Affordable Care Act protections under the IRS rules, there's not a specific right for a consumer to sue under that law. And so it's really up to the IRS to enforce that provision of the law. In the second part of the Model Act, there's more detail about debt collection and credit reporting protections for consumers. So there's a blanket prohibition on certain collection actions. And the Model Act says that no one should be arrested over medical debt. There should be a writ of body attachment or capias warrant, which is sort of a civil arrest. And arrests over medical debt, it can happen if someone has been sued and they've, it often arises where the patient has been sued. Maybe they've appeared in court or maybe they've defaulted initially, but often there'll be a second proceeding where they'll be called back to have their assets examined or income examined to see if they can pay more than what they were already required to pay if there was a payment plan set up. And if someone doesn't show up for that, then there could be a warrant issued for them if they're found in contempt of court. The ACLU did a great report on this called A Pound of Flesh, on the use of civil arrest warrants for debt collection suits. Foreclosure on an individual's real property on a home would be prohibited, and garnishing the wages or intercepting the state income tax refunds of a patient who'd be eligible for financial assistance. The Model Act also proposes no credit reporting of medical debt for a year, so going beyond the protection I talked about earlier, which was 180 days. No credit reporting or collections while an insurance appeal is pending. So if a patient is disputing with their insurance company whether the insurance company should have covered something, that should pause collections or credit reporting, cap on interest rates, and requirement for reasonable payment plans. There are a number of states that right now have some medical debt reform bills that are kind of similar to the things that I just talked about that are in the Model Act. And so you can see the list here: California, Connecticut, New York, Texas, Vermont. And as far as I know, those are all still pending before the legislatures, and two that have passed are, which is very exciting, are in Maryland, which Marceline will talk about in a little bit, and New Mexico. There are two pieces of federal legislation that are pending that address credit reports and debt collection rights for medical debt. So this bill by Senator Merkley and Representative Porter would require the removal of paid off or settled medical debt from a credit report. Right now, consumers often don't realize that if you see a medical debt show up on your credit report and you rush to pay it, thinking that it's going to immediately vanish from your credit report, it's not necessarily the case. But there should at least be some sort of notation saying that it was paid. If it was the responsibility of the insurance company, then it should be removed or made clear that it was the responsibility of the insurance company. But this bill would go farther. It would delay the reporting of all medical debt on the credit report for a year, and would provide a timetable for verification of medical debt. So that's the consumer's right to get an explanation of the medical debt from a debt collector. And there is also the COVID-19 medical debt protection bill introduced by Senator Van Hollen, that would pause medical debt collections during the pandemic and for 18 months afterwards. And then for COVID-19 related testing or treatment would put a permanent prohibition on certain types of collection actions for that treatment that's related to COVID-19. So here's a list of some NCLC resources that are available on our website, and you can take a look, and I will now hand it over to Marceline.
Thank you so much, Jennifer. This is great. It's like a wealth of information. And so what I'm hoping to do is now talk a little bit about what this actually looked like in Maryland on the ground. I'm going to try to share my screen. So what I'm going to talk about is about the state campaign in Maryland, what that looked like, what we did, and a little bit about how we did it, just to give everyone a sense of what this kind of campaign can look like on the ground. So I'm going to talk a little bit about what the legislation did. Just so you know, the legislation has passed. It passed the House and the Senate. So our governor can either sign the bill into law, he can let the bill pass without signing it and let it become law, or he could veto it, but we don't anticipate a veto because it passed unanimously in both chambers. So obviously, a lot of the Medical Debt Protection Act, which we passed, was based on NCLC's model law, as well as some of the work that has already been done, the groundwork laid in other states like Oregon and California. So what the bill does is it expands the timeline to qualify for free and reduced cost care to 240 days after the initial bill, requires an annual report by each hospital on their debt collection activity, And that annual report on debt collection activity is disaggregated by race, zip code, sex, and a lot of demographic detail. So as NCRC members, if you think about HMDA data, that's kind of the level of detail we're trying to get to when we talk about the debt collection activity that the hospitals are going to have to report and publicly post. Again, it prohibits reporting to Consumer Reporting Agency for 180 days. No interest or fees on debt for patients who qualify for free and reduced care. Income-based repayment plans, we think, are critically important in Maryland because we know so many patients who are above, who wouldn't qualify for free or reduced cost care, but still don't have $1,000 or $5,000 in order to basically pay their bill outright. So this will create guidelines starting in June. It'll convene a work group, and the income-based repayment plan will be for all patients with medical debt of no more than 5% of the patient's gross monthly income. And along with that, there's essentially a de facto moratorium on medical debt lawsuits. So what that means is from the time the bill is passed until hospitals have all developed policies for income-based repayment plans and are able to implement these payment plans, there will be no medical debt lawsuits, no legal actions. So the earliest that we could see legal actions again would be January 2022, but we think it'll actually be later than that. Couple other things it does, requires an affidavit from the hospital before they can send anything to debt collection, showing that the hospital made a good faith effort to create a payment plan. So again, put some more consumer protections in place before they can send something to collections. No reporting to the credit, no adverse reporting if they were eligible for free or reduced care, or if an appeal is underway. Again, hearkening back to some of the stuff Jennifer talked about, no liens are allowed on a patient's primary residence at all. That's, doesn't matter if they have free or reduced cost care or other medical debt, you can't put a lien on someone's home. Unfortunately, you could still pursue their estate after they died. So that's something we want to continue to work on. No body attachments. Again, you can't jail somebody because of medical debt. And no wage garnishment for patients eligible for free or reduced care. So we're very proud of the work that we have done. It is a very strong bill. There were a lot of other things that were in the original bill that we didn't get, but that just leaves us work to do next year and going forward to pass even stronger protections. So I'm just going to talk a little bit about how we got here. For those who don't know, Maryland's legislative session is 90 days. Maryland has a Republican governor, but a Democratic majority, a veto-proof majority in the House and the Senate in our chamber. But in some ways, it's a very purple state. So there are very conservative areas of the state and more liberal areas of the state. So oftentimes, it's very difficult to pass strong legislation that protects consumers. As you'll see that it played into our strategy. So we introduced this bill the first time in 2020, and we introduced it along with a companion bill. The companion bill was introduced to expand access and eligibility for those who would get free and reduced cost care, really trying to address the issue upstream before it became a collection issue. That bill passed. This bill to look at debt collection, again, the kind of downstream effect did not pass in 2020. The reason we decided to work on this bill is because we've been working on other debt collection issues. And one of the things that kept emerging is this view in Maryland that a person is at fault if they're in debt, they're to blame, but medical debt was different. And so at the same time that we were really wanting to call people on their claims that medical debt was different, we were also seeing rising healthcare costs across the state and seeing this issue of debt collection, looking at NCLC and others reports. So we also knew that medical debt collection was a huge issue for consumers, and one that we could address in a hopefully more comprehensive way and nail it down. So this bill died in 2020. Our legislative session was cut short by 3 weeks because of COVID-19. There's also very strong opposition from the Maryland Hospital Association. And just so you understand, our healthcare model in Maryland, all hospitals are nonprofit and they're exempt from taxes. And in exchange, they're required to provide free or reduced cost care. But in addition, we have an all-payer system, which means that the state reimburses hospitals for the charity care that they provide, which means that there's a state commission that sets up the formula for which hospitals are paid. And that includes in that formula money to cover the cost of providing free or reduced cost care. And that's referred to as the charity care rate support. So they're obligated to provide the care, but they don't have to bear the cost. But Marylanders are very concerned that something may happen to this model and that any changes to the model could break the model and mean that we had to pay more in care. So the Maryland Hospital Association in 2020 raised fears that anything that would happen might destroy this model and we couldn't go forward. So in the interim, in 2020, we did work and we built on that in this year. So in 2020, we worked with the AFL-CIO and the National Nurses United to really document the problem in Maryland. And I'm just going to give you a couple quick examples of our report. The report was called Preying on Patients. I'll talk about it again. But we looked at each county in Maryland and what happened in each county in terms of medical debt collection. So Hartford County is a small, more conservative county, but you can see there were 3,311 lawsuits filed. 1,050 was the median debt, and 724 families whose wages were garnished. And then we also have information from another report about the number of people living in poverty and struggling financially in that county. So that gives you a little kind of snapshot of what's happening. And we have that for each county in Maryland through the research. There's a link to the report. It's called Preying on Patients. And statewide, we found over a 9-year period, there was 145,746 lawsuits to collect medical debt, hospital medical debt. This is all hospital medical debt of $5,000 or less. The median amount pursued was $944, more than 37,000 garnishments, more than 4,000 liens on homes, and more than 3,000 bankruptcies because of the hospital medical debt. We were also able to look at the fact that this medical debt hospitals were pursuing was 0.18% of their operating revenue and 4.7% of their net income. So we used those statistics, and then we also looked at the disparities. So this was just looking again at the racial disparities in terms of residents with medical debt and collection. And you can see that statewide, and then we broke it down into several key counties. So you can see the disparate impact. So we did the research, we documented the problem, and we also, going into 2021, looked very quickly and closely at COVID-19 and pushed for this as an emergency response, both because in Maryland, there was a huge number of workers lost their jobs. So that meant they lost employer-based health insurance in the pandemic. We also know that there are a number of essential workers, and these are predominantly Black and Hispanic workers who were still continuing to work, often in low-wage jobs, but they were considered essential workers. So we wanted to extend protections to them because there were arguments in our state about supplying them with the needed protections. We also raised the public health concerns. Both the idea that people could lose their homes in a public health crisis and need to move in with other residents raised concerns during COVID, and the fact that COVID long haulers and those who survive COVID often emerge with long-term healthcare needs, both those with COVID long haulers, but also people who've emerged from the crisis with diminished lung capacity, lung damage, and heart damage. So we need to be responsive in that way. And then, of course, as noted, there's a disparate impact of COVID in our communities, with our communities of color bearing a larger brunt, both of those who've had lost lives because of COVID, had harder and more difficult consequences with COVID, and lost more jobs. So we introduced the legislation and focused on the things that passed, as well as prohibiting lawsuits for $1,000 or less. So in addition to highlighting COVID and making it an urgent issue, we organized, we built out with a number of groups, a coalition called End Medical Debt Maryland. MCRC, my group, was one of the lead organizations, but 1199, National Nurses United, Progressive Maryland were others. In the end, it became 58 organizations representing more than 400,000 Marylanders. So that obviously had a huge impact on what we were able to do and the pressure we were able to bear in the state assembly. We also commissioned a statewide poll to show that there was a problem and that there was strong support for the legislation, to give the legislators the support they needed to take strong action against the hospitals, which spent more than $400,000 this year trying to beat this legislation. So you can see here, if you had a $500 medical debt to pay today, where would the money come from? And there's a huge discrepancy between African-American and white borrowers in terms of would they be able to pay it, would they not pay, or would they have to use their credit card? So we wanted to document the problem. We also wanted to show that there was broad support for this issue. So again, you can see that more than 60% of people support prohibiting hospitals from suing former patients for debts under $1,000. And again, 93% of those surveyed of poll participants support some kind of income-based repayment plan. And again, we're showing this is across Democrats, Republicans, Independents. This is a bipartisan issue. We did do more research as well. As we noted in 2020, the concern was raised about what this would do to the cost of care model. The organization who was supposed to do that study didn't do it because really of COVID. So we commissioned a study. I can put that in the chat. There's a link here by two BU health economists to estimate the effect. They found it would cost hospitals on average $7,000 to stop suing on medical debt. And again, this was important because the argument from the hospitals was that it would have devastating consequences, but there was no study done, and they did no study to argue against it or to prove that. So our study was the one out there showing that it would be reasonable to stop. We also created a medical debt freedom fund, which is a direct action effort to pay off medical debt and to gather stories. And through the coalition, we gathered a large number of testimonies. A gentleman who lost his family's home because they put a lien on the home for a $6,000 debt. A woman who had good health insurance but was still pursued for collection, and they wouldn't negotiate with her or try to help her resolve the problem. And then another person whose grandmother refused life-saving treatment because she didn't want her grandchildren to have to deal with their medical debt. So just heart-wrenching stories. And these people were brave enough to share their stories with legislators and the media to draw home the human impact of these actions. The legislative organizing, we focused on committees because in Maryland, almost all the work happens within the committees. By the time something gets out of the committee, it's often likely to pass. So we focused on those committees. It's the third year, the year before election. So this is often when big important bills happen, because next year they're going to all be thinking about re-election. Having coalition members who endorse and provide funding for candidates was very important. We're a C3, so we don't do either of those things, but having labor, having civil rights leaders like the NAACP and others, having faith leaders helped us have a strong ground game. We had a core group of people that I led the organizing of who advocated in Annapolis, well, virtually advocated and did the legislative advocacy. Then we had a whole other group of people who were doing the mobilizing and outside mobilizing and the social media and the kind of grassroots organizing. So all of those things came together to help us win support. Another thing that happened is that the Healthcare Commission had to issue a report this year because of the legislation that did pass last year, looking at what it would mean to raise eligibility for free and reduced cost care. The report was released in the middle of session, and it was pretty damning. It found that 60% of the patients hospitals sued for medical debt should have qualified for free care. So that also made the case for us that the system needed to change, and they were sending people to debt that should have gotten free care. And those patients who should have gotten free care paid hospitals $61 million. So all of those things combined to help create a very clear environment. Some action needed to happen, and it had to be strong. The coalition, the End Medical Debt Coalition, is continuing to work. So we're going to be working next year on multiple bills. It's an election year, which means it'll be harder to pass bills. But we want one bill that's just a one-page bill on prohibiting lawsuits for medical debts that are $1,000 or under, to really try to get them to take a vote on it. Others are looking at some tweaks to language. This year, we passed originally language that would prohibit a lien on an estate, a lien on a home, but also on the estate. So we'd like to restore that language. And there are some places where they cut protections for a reduced cost care that we'd like to see restored. And we also want to be looking at the hospital's debt collection contracts and assess whether there's action there, and participate in the working groups on the income-based repayment. So that's a deep dive of how one state did it. I'm happy to answer questions. You can find more information out about the poll, the study, and the report on our website. You can follow us on Twitter or follow End Medical Debt Maryland. I'm happy to talk to people as well later on about any tips, questions, or anything else you want to talk about in terms of this. And I really thank you for your time. We appreciate talking to you about these issues. I am muted.
Hi, everyone. Yeah.
Hi. Hello.
Everybody.
Thanks so much. I saw a couple questions in the chat. I know it looked like there was a question about whether or not the medical debt lawsuits in Maryland differed by county and also by procedure. So they did differ by county. In the report, we have an aggregate of all the hospitals and lawsuits in the state, and then we disaggregated by county, in part because there are different systems. Like University of Maryland medical system is in multiple counties, as is Johns Hopkins, but also there were some hospitals that didn't sue at all. So it's important for us to have been able to contrast the hospitals who had none or a very small number of lawsuits versus the ones who were aggressive at suing. We did not get into detail in the survey about the medical procedures because we used a database that looked at the lawsuits at the court. So we looked at the court files, and when we scraped the database, we could find the amount, the hospital, but we didn't get into detail about what procedure it was. And similarly, yeah, we couldn't get into detail about the sex of the patient. We know from one of the people who testified, some people have been sued for IVF and similar kinds of issues. We got that from testimony, but it was more of a quantitative analysis, and there wasn't that level of detail. We would have had to go in record by record to do more.
I saw there was a question about negotiating with the hospitals. Marceline, maybe I'll just quickly answer that one, I think. There was a question that seems counterintuitive that insurance companies can negotiate, but individuals can't. And I should just say that, Yeah, individuals can actually can try to, once they get a medical bill, can try to negotiate with the healthcare provider if they're not able to pay that amount. And when I used to directly represent clients at an organization called Health Law Advocates, sometimes I would do that on their behalf. That if we had sort of chased down every possible type of insurance or every other source to pay it. And kind of got to a dead end and there was just a bill for the patient, then the next step would be to go back to the healthcare provider and to try to negotiate a lower rate. And sometimes the patient was charged the charge master rate or the sticker price that we talked about for healthcare, so the absolute highest price. And we would often be able to get that negotiated down to the Medicare reimbursement rate, which is usually less than half of that charge master price. The only problem with that approach, of course, is it puts all the burden on the patient to have to go and engage with the healthcare provider.
Great. I saw a question in here too about the research and about patterns in terms of who sued and didn't sue. And Jason, it was primarily religious hospitals that didn't sue. Although in Maryland, all hospitals are nonprofit, but it was the religious hospitals that weren't suing. But that wasn't true across the board either. Mercy Medical, which is a Catholic hospital in Baltimore City, was one of the more aggressive in terms of pursuing the debt. So there's nothing cut and dried. It really is. It took a real granular analysis, so there wasn't any sweeping pattern, unfortunately. And it looks like there was a question about the partners. I know from Maryland's experience, we were able to build out a pretty strong coalition. So we ended up having 58 partners representing 400,000 Marylanders, which was great, and it was a fairly diverse coalition. The year before, when we were working on this, we didn't have as much success, but I think it was honestly a capacity issue, just in terms of having someone who could be dedicated to focusing on building out the coalition. And this year, one of the labor unions basically dedicated one of their political organizers to it full time. So we just had a lot more capacity to actually have someone focusing on the coalition part. Yeah, and there's questions about the demographics of the board. Yeah, I mean, it might be. I don't know. Some of them are pretty big systems. Like Johns Hopkins, obviously, is the elephant in the room.
There was a question too, I think, about the Maryland research, maybe about whether there were any trends along gender. I guess
we don't have it.
Demographic.
Yeah, we don't have it just because of the nature of the research in terms of the data we were looking at. And actually, I think you might be able to answer this one, Jen. Josh was asking about whether or not we anticipate lawsuits in terms of the payment plan requirements. So in Maryland, we're going to require, income-based repayment plans. And so the question is whether or not we anticipate lawsuits. And that's a great question for you, because I don't know.
I mean, I would hope not. I would hope that once, the hospital entered a payment plan with the patient, there's two kinds of lawsuits this could refer to, whether the hospitals would try to sue saying that they shouldn't be required to do payment plans. And hopefully that won't happen. I mean, based on all your advocacy. But, on an individual basis, would patients be sued if they didn't comply with the payment plan? I would hope not. I think that kind of remains to be seen. It's not, this isn't a requirement that a lot of states have, so we don't really have a lot of experience with something like this. And then I did see there was another question. Maybe we could both, might both have something to add to this, whether there's evidence to suggest certain subpopulations are more likely to have medical debt because of the nature of care and as a result of unintentional discrimination toward or emphasis on certain demographic groups. And I don't know if this is exactly what the question is looking for, but I think, there's an emerging amount of data about racial disparities in medical debt, and that there really is a big racial justice component to this problem. That there are parts of the countries that have more for-profit hospitals where there might be less availability of charity care. There might also be less availability of Medicaid, and so there could be more patients in certain parts of the country then who end up getting stuck with a bill that they can't afford. I think there also is a higher rate of people being uninsured who are African American or who are Latinx. And so, there could be patients who are more exposed to medical debt for that reason too, because of the lack of insurance. And then kind of a bigger piece that I think is, beyond the scope of like what I work on as a consumer advocate, but there's certainly, a lot of kind of emerging research out there about uh, the racial inequities in the healthcare system itself, and how if you're a person of color, you might have a harder time accessing care and having your concerns listened to and treated seriously. And so, if you're not getting as good care as someone else who's in a different demographic group, then that might lead to the need for more expensive care further down the road and more risk of medical debt. So that's a good question. I think there's a lot of complicated factors.
Yeah, and I can just add from what we saw in Maryland, um, we know that 3 times as many of the lawsuits were taking place in predominantly low income areas. And if you're looking at mapping that, those were also areas that were predominantly African American. So Johns Hopkins is a good example because the area surrounding Hopkins was a tradition has been a red line community, a community that has been disinvested in for a number of years, and is one of the highest areas where Johns Hopkins is suing. So you do have that quantitative data in our work as well as in the polling we did. There was a huge discrepancy between white voters and black voters about if you had a $500 medical debt, would you be able to pay it or what would you do? With, again, because of the racial wealth gap, the historic racial wealth gap, black voters were far less likely to be able to pay the bill outright. They'd either have to just ignore the bill or really max out a credit card, or use their credit card. So again, kind of historical racial injustices and inequities contribute to the fact that there just isn't as much money to pay a bill outright for a lot of low income, predominantly African American neighborhood communities. And again, like in Maryland, we also know because of redline communities and the lack of investment overall, you have a lot of communities with higher rates of asthma. In Baltimore City, you have places with higher rates of lead poisoning. You have places with communities that have been redlined that are traditionally Black communities with higher rates of diabetes because of food deserts. So all of those kind of health disparities combine and contribute to the likelihood that they're going to be sued more aggressively and sued more often. Again, and that's for us one of the reasons why the NAACP in Maryland was a strong proponent of the bill, which was very helpful in terms of making those arguments and explaining those connections.
And, Marceline, I think one of the pieces of data that was included in the report was also really kind of compelling to show why, it's not just medical debt, but really all debt collections that we need to have stronger consumer protections because, there you had reported research about how many people need to put medical debt on a credit card. So once you put medical debt on a credit card, it's not going to look like medical debt anymore. It's going to look like credit card debt. And it's kind of part of the reason we need, a broad set of consumer protections that don't just apply to medical debt.
Yeah, absolutely. Absolutely. And yeah, so we'll see as we go forward what the income-based repayment plans look like. Kind of our hope is that if that gets in place, it'll help broadly, not just people who should have gotten free or reduced cost care. Because again, we can probably think of family and friends and colleagues who don't have $5,000 to just take out and cover an unexpected medical expense. And so, it should allow everyone to pay the debt back over time in a way that's sustainable and is not, an egregious percentage of their monthly wages. Great. So it looks like we're right at time. So I don't know if there's a last question or not, but we really appreciate you all being here and listening. And again, happy to answer any other questions. And I'm happy to share the research. There's a link in the slide, but I'm also happy to share that if people want to see the full reports for the debt, the Gallup, the polling data, or for the health economist study. Thank you.
Thanks, everyone.
Thanks. Bye.